Okay, we are going to discuss carcinoma rectum and anus. So we are going to discuss the malignant disease of anus and rectum now. Before going to the detailed discussion of rectum and anus, let us have a classification of tumors in the rectum and anus. So please don't forget. So rectal cancer is always adenocarcinoma. We all know very well, it's mostly adenocarcinoma. So it is adenocancer, and it is most of the points related to adenocarcinoma is already discussed in colon chapter. And then anus. In anus, I already told you there is a line known as pectinate line. Above this line is made up of columnar epithelium. Above this line is made up of columnar epithelium, and below is made up of squamous epithelium. So therefore, the cancer in these two places are little different. They are little different. Okay. So distal to the dentate line or pectinate line in this place, the cancers are given a name known as anal margin cancers. Okay, anal margin, which is nothing but skin. Actually, this is actually a skin. So like a skin, we'll get all skin cancers like squamous cell cancer, basal cell cancer, verrucous cancer, Bowen's disease. Like these are all like a similar to skin cancer. Squamous cell, basal cell, verrucous, Bowen's are the tumors seen in the squamous cell lined part known as anal margin cancers. They are known as anal margin cancers. And coming to the columnar epithelium, we can get cancer here. What are the cancers you get here? Because it is lined by columnar epithelium. They are known as adenocarcinomas. Here we get adenocarcinomas. We get adenocancers. We get epidermoid cancers. The cancer is known as epidermoid cancers, and we also get malignant melanoma. Though it is a skin cancer, commonly seen in the skin, malignant melanoma is also seen in these places. Okay, so malignant melanoma in the anus is the third common site. After skin followed by eye, the third common site is anus. So these are the three common sites of malignant melanoma: skin followed by eye followed by anus. And these cancers in this columnar epithelium are known as anal canal cancers. They are known as anal canal cancers. So they will be given a name known as anal canal cancers. So please remember, this is the classification of rectoanal cancers. Rectal cancers are always adenocarcinomas. They are always adenocancers. And this is the most common site of colorectal cancers. Rectum is a common site. We have already discussed. 30 to 40% is seen in rectum. And anal cancers are lined by columnar epithelium and squamous epithelium. We have two cancers. One is anal canal cancers, another is anal margin cancer. Can you tell me which is most common among all these anal cancers? Among all these anal cancers, the most common type is squamous cell cancer of anal canal is the most common type. The most common type of cancer in the anus is squamous cell cancer of anus. Please don't forget this point. Okay, squamous cell cancer in the anal margin is the most common type of anus cancers. So now coming to the clinical features. Clinical features of rectoanal cancers, the most common presentation of them is bleeding PR. They commonly present to you as bleeding PR. And early morning spurious diarrhea. Please remember, this is a classical feature of rectal proliferative cancer. Early morning spurious diarrhea. This is a classical MCQ from Bailey & Lowe. Please don't forget this. The patient will wake up in the morning. This is the anus. Will wake up in the morning. He is having a proliferative growth like this in the rectal ampulla. So what happens? Overnight, there will be secretion seen that will be getting collected in the anus. And as he goes and sits in the latrine, he will first pass the mucus discharge like a diarrhea. After that only the stool will come out. So this is what we say as early morning spurious diarrhea. So please don't forget, early morning spurious diarrhea is a classical feature of rectal proliferative growth. So bleeding per rectum, early morning spurious diarrhea, okay, are all classical features of rectoanal cancers. Okay, rectoanal cancers. So now this patient comes to you. So investigation of choice for rectal cancer. Can you tell me what is the investigation of choice for rectal cancer? So rectal cancer, the investigation of choice to diagnose, to do T staging, to do N staging, to do M staging, and tumor marker. So you have to know all the answers. So to diagnose is by means of sigmoidoscopy and biopsy. Sigmoidoscopic biopsy. We have to do sigmoidoscopy and we have to take biopsy. So T staging, N staging, the latest answer is surface coil MRI. Surface coil MRI pelvis. MRI pelvis. So why I am taking the surface coil? Because 2 years back the answer was endo coil MRI. We have to put a tube containing MRI inside the anus and we have to take. But that is now not done. We are now doing surface coil MRI. MRI pelvis is the best for T staging and N staging of cancer rectum now. For T staging and N staging of cancer rectum, now the best is MRI pelvis. And for M staging, the most common site of distant mets is to liver, followed by lungs. So what do you think will be the best answer here? It is CECT abdomen. CECT abdomen and pelvis should be done for M staging. And tumor marker is already discussed for colon cancer. Same CEA is used for rectal cancer also. So CEA is used for rectal cancer also. Please don't forget, CEA is a tumor marker for rectal cancer also. So for rectal cancer, so diagnosis is by sigmoidoscopy biopsy. We have to identify the exact location from anal verge should be noted. Exact location from anal verge should be noted, and involvement of any sphincter will be seen on sigmoidoscopy. And we have to look for any incontinence. All those things we have to look in sigmoidoscopy, and we have to do MRI to look for Pakka TNM staging. For Pakka TNM staging, we should do MRI. So now let us assume I am drawing the rectum in a different pattern, in a straight way. After you mobilize the Houston walls, please remember, after you mobilize the 3 Houston walls, you will get an extra length of rectum of around 5 centimeters. You can get a rectum length of added 5 centimeters will be obtained after you mobilize the Houston walls. Now let us assume the rectum is divided into 3 parts. So this is upper, this is middle, this is lower. Let us assume each part of rectum is 5 centimeter, 5 centimeter, 5 centimeter. And please remember, this is puborectalis muscle, which is very important muscle for continence, very important muscle for continence. And this is the 4 centimeter of anus. This is 4 centimeter of anus. And this is the dentate line seen exactly at 2 centimeter from anal verge. Puborectalis muscle is seen at 4 centimeter from anal verge. On a sigmoidoscopy, 2 centimeter from anal verge is the dentate line. This is dentate line. 4 centimeter from the anal verge is puborectalis muscle. Very important muscle for continence. And the rectum is 5 centimeter, 5 centimeter, 5 centimeter, 3 parts. And the upper rectum is fully in the intraperitoneum like this. This is the peritoneal covering. So upper rectum is fully inside the peritoneal cavity, which is within the peritoneum. Middle rectum partially retroperitoneal. Lower rectum is totally retroperitoneal, totally extraperitoneal. Okay, now with this anatomy in your mind, we are going to discuss some surgeries. Please understand the surgeries. If there is a cancer in the rectum like this, proximally we go and cut up to sigmoid colon. So don't worry about it. The centimeter where you go and cut is not important proximally, because we go and cut up to sigmoid colon. But distally, how long will you go and cut? That is MCQ. Distal margin for cancer rectum, because that is very important in deciding the type of operation. Distal margin is 2 centimeter. If you give neoadjuvant chemo RT, it is 1 centimeter. So the distal margin of rectal cancer is 2 centimeter margin. If you give neoadjuvant chemo RT, it is 1 centimeter margin. Please don't forget this rule. This is the rule. So the margin clearance for cancer rectum, a straightforward operation, we give 2 centimeter clearance, and for a neoadjuvant chemo RT cases, we give 1 centimeter clearance. And after giving clearance, for example, if there is a cancer here, I will cut the tumor here and anastomose the proximal bowel with this, like as I'm drawing here. So the proximal sigmoid colon will be now anastomosed with the distal rectum like this. This is the distal rectum and this is anus. So now there is anastomosis done like this. This is colorectal anastomosis done. So after the removal of specimen, this is a rectal cancer which is removed by giving a 2 centimeter clearance distally, by giving a 2 centimeter rectal clearance like this. What is the name of this operation? This operation for cancer rectum is known as anterior resection operation. So very important topic for PG level. Many times the students get confused in this. Please remember this topic. Anterior resection operation is an operation in which we give 2 centimeter clearance for the tumor and give a proximal adequate clearance and remove the tumor and give a colorectal anastomosis. Usually this anterior resection is done with the help of circular staplers. We use circular staplers for doing this anastomosis. You can do also hands one, but most of the surgeons use circular stapler. Okay, this is known as anterior resection. We give clearance and we anastomose. That is known as anterior resection operation. So if the anterior resection operation and anastomosis here are done above the peritoneal reflection, if it is done above the peritoneal reflection, it is known as high anterior resection. High anterior resection. If there is a cancer here in the extra retroperitoneal part and we give 2 centimeter clearance and we do the anastomosis below this peritoneal reflection is known as low anterior resection. So there are 2 types of anterior resection for PG level. Please remember, high anterior resection is above this peritoneal reflection. And anastomosis done above the peritoneal reflection is high anterior resection. And anastomosis done below the peritoneal reflection is low anterior resection. So low anterior resection is a very low anastomosis. So please remember, low anterior resection is a very low anastomosis like this, just anastomosing very close to the rectum, puborectalis muscle and anus. So there are chances of leak more common in these places. So when you do low anterior resection very close to the recto-anal junction, we can do a covering ileostomy for this anastomosis to heal. So this is a temporary covering diversion ileostomy. So that even if there is a leak coming from this anastomosis, the motion will be proximally diverted in the ileostomy and there won't be pelvic sepsis, to avoid pelvic sepsis. Okay, to avoid pelvic sepsis on leak. But it is not always done for PG level. Please remember, it is done when you do a low anterior resection in selected cases, not all cases. So what are the selected cases? The super specialty level points are not needed for you. So please remember, when will you do low anterior resection? So when will you do high anterior resection? High anterior resection is above the peritoneal reflection. Low anterior resection is below the peritoneal reflection. Please don't forget this point. So please don't forget, after anterior resection operation, we do a colorectal anastomosis and patient will pass motion through the anus. He will pass motion through the anus. So we prefer most of the time to do anterior resection operation for cancer rectum. Okay, we prefer to do anterior resection most of the time. But sometimes, please see the picture again. If there is a cancer very low in the rectum like this, and if you want to give 2 centimeter clearance, there is chances of injury to the puborectalis muscle and the patient will land up in incontinence. So what we will do in such cases? In such cases where the tumor is very close to the puborectalis muscle, we should go for another operation known as abdominoperineal resection. Abdominoperineal resection, in which you remove the entire rectum and anus. Entire rectum and anus is removed and we do a, what do you do for them? Lifelong. So we have to remove the anus, rectum, everything. For example, if the cancer is very low like this, we have to remove this completely. And we have to do a proximal permanent colostomy like this. The growth will be removed out along with the anus like this. The growth will be removed out and the patient will land up in permanent colostomy like this, known as abdominoperineal resection. So initially done by Miles, they used to say as Miles operation. So initially done by Miles, hence known as Miles operation. So please remember, abdominoperineal resection, the patient has to live with lifelong colostomy. So lifelong colostomy has to be there for the patient, and most of the patients will get depressed on getting this surgery. They will not be ready for coming to this operation. They will end up in lifelong colostomy and they will not be ready for coming to this operation. Please don't forget, this is known as abdominoperineal resection of Miles. Operation. How to say whether we can do anterior resection operation or we have to do APR operation? This is a very important PG question. How to say whether we can do AR or APR? Very simple formula. This is puborectalis muscle. This is anus. Now from anus, you put a sigmoidoscopy. If the growth is seen above 6 centimeters, this is 4, this is 2. So if the growth is seen above 6 centimeters from anal verge, you can go for anterior resection. If it is less than 6 centimeters from anal verge, you should go for APR. No doubt, if the cancer is here, what we will do? If the cancer is here, it is very close to the puborectalis, so we have to remove the muscle. So if the cancer is above, we will do only anterior resection operation. Above 6 centimeters, anterior resection, below 6 centimeters, APR from anal verge. And sometimes the AIMS exam asks this not as anal verge and they mention as dentate line. So dentate line is minus 2 centimeter, that's all. It is minus 2 centimeter. So more than 4 centimeter from dentate line we do anterior resection and less than 4 centimeter from dentate line we do APR. That's all, no difference. From anal verge, it is coming as AR and APR. From dentate line, it is AR and APR. So it is based on the distance from the puborectalis. Less than 4 centimeter from dentate line AR. So more than 4 centimeter from dentate line AR. More than 6 centimeters from dentate line AR. Less than 4 centimeters from dentate line APR. Less than 6 centimeters from dentate line APR. This is all purely based on the concept we have to give 2 centimeter distal margin. Please don't forget these 2 surgeries. These are 2 high yield MCQ topics. And apart from this, you also should know, if this is a rectum, rectum has one attachment posteriorly like this. What is this attachment? That is attached posteriorly like this. What is the name of this attachment? This is known as mesorectum. All the nodes from the rectal cancer, for example, if there is a cancer here, all the nodes will be present in the mesorectum only. Therefore, we have to remove the mesorectum also. Mesorectal excision is also advised to prevent recurrence. Mesorectal resection how many centimeter mesorectal excision should be done? We call it as 5 centimeter from the tumor. For example, if there is a tumor, the mesorectum should be excised at 5 centimeter distance. Cancer will be excised lumen at 2 centimeter. So luminal clearance is 2 centimeter, mesorectal clearance is 5 centimeter. And especially if there is a cancer in the lower rectum like this is a lower rectum cancer, we should remove TME. What is TME? Total mesorectum should be removed. TME, total mesorectal excision done. So total mesorectal excision done if the tumor is in the lower third of rectum. So if the tumor is in the lower third of rectum, we should do total mesorectal excision. Please don't forget this. So please remember the margins, what I'm telling now. Margin clearances. So distal margin for lumen is 2 centimeter for cancer rectum and 1 centimeter for post chemo RT patients. Post chemo RT patients 1 centimeter. And mesorectum, how many centimeter clearance? Distal you must give is 5 centimeter. Okay. And circumferential resection margin. Circumferential resection margin is given 1 millimeter margin. So these are the margins given in books. So circumferential means if this is a tumor, the circumferential margin should be 1 millimeter margin for the clearance. So 1 millimeter circumferential resection margin, mesorectum 5, lumen 2 and 1. Okay. And cancer rectum, how does it differ from cancer colon? We have already discussed cancer colon. I hope you all remember the discussion on cancer colon. So in cancer colon and cancer rectum, the following are the differences in the management. In cancer colon, the moment you diagnose the patients, there is no role of neoadjuvant therapy. No neoadjuvant therapy available there. No neoadjuvant. Directly you go for surgery. Directly we go for surgery. But for cancer rectum, there is neoadjuvant advice for locally advanced cases. Locally advanced cancer rectum, we can give neoadjuvant chemotherapy or radiotherapy can be advised. Especially radiotherapy has a role in cancer rectum. There is a role in cancer rectum. There are 2 types of radiotherapy. Long course radiotherapy, which is given for 6 weeks before surgery. 6 weeks of radiotherapy is given before surgery is long course. Another is short course radiotherapy, which is given only for 5 days before surgery. There are 2 types of neoadjuvant radiotherapy. Before surgery, radiotherapy given or long course radiotherapy for 6 weeks, and short course is given just for 5 days and operate immediately. So long course radiotherapy you will give and operate after 6 weeks. 6 weeks radiotherapy followed by 6 weeks gap and then operate. Totally you wait for 3 months in a long course. So nowadays therefore people are preferring to go for short course therapy. Just give 5 days radiotherapy and operate in next week itself. Okay, that is short course. So that is the first difference. There is no neoadjuvant available for cancer colon, but for cancer rectum there is neoadjuvant chemo and RT available. And for colon cancers we discussed right hemicolectomy, left hemicolectomy, and we also discussed about extended right hemicolectomy. These are the operations done for colon cancer. For cancer rectum we have APR operation if the cancer is close to the puborectalis muscle, high anterior resection above the peritoneal reflection, low anterior resection below the peritoneal reflection. And there is one more operation for cancer rectum known as Brunstwig operation. What is it? Not done nowadays, just for completion telling. Brunstwig operation. What is it? Brunstwig is pelvic eventration operation. For a cancer involving and infiltrating to the lateral areas, we do a pelvic eventration operation known as Brunstwig operation. Brunstwig is pelvic eventration operation of cancer rectum, in which we do a major resection involving the adjacent organs also, that is Brunstwig. And there is one more technique of radiotherapy known as Papillon technique. What is Papillon technique of radiotherapy? For patients who are not fit for surgery, we give intracavitary radiotherapy, that is known as intracavitary. We put needle inside the tumor and we give radiotherapy known as Papillon technique of radiotherapy. It is a type of radiotherapy to the rectal, lower rectal or middle rectal cancers. We can directly give radiotherapy to them. So these are like that. Many options are available for cancer rectum, and in fact for cancer rectum now there is a transanal excision is also available. Transanal excision is also available for cancer rectum by various modes. Transanal excision of the cancer rectum is also available for cancer rectum. It is a local resection. It is a local resection by using minimally invasive methods or using a special endoscopic procedures like TEMS, TAMIs. So these are all methods by which transanal endoscopic microsurgery. So transanal endoscopic microsurgery is TEMS. Transanal endoscopic microsurgery is done, or transanal minimally invasive surgery is TAMIs. Transanal minimally invasive surgery is TAMIs. This is indicated for the following tumors: T1 tumors, involvement only mucosa and submucosa, and this is useful for mobile tumors only. This is useful for tumors which are less than 3 cm and less than 30% of the circumference of the lumen. So this is useful for less than 3 cm and less than 30% of the circumference of the lumen. And fifth point, the tumor will be available in the 4 to 8 centimeters from anal verge. Tumor is seen 4 to 8 centimeters from anal verge. That is the patient we use. So the tumor should be moderately differentiated tumor. Moderately differentiated tumors and no nodal disease on MRI, no nodal mets. So these are the indications of doing a TAMIs or TEMS. So when can you do TAMIs or TEMS is when the tumor is seen in the distal 4 to 8 centimeter. Distal 4 to 8 centimeter, we can give margin like this and we can remove the tumor. It should be T1, it should be less than 3 centimeter size, it should be less than 30% circumference of the lumen. So these are the places where we can do cancer rectum local resection. We can do local resection of cancer rectum. Okay, please don't forget these points in cancer rectum. And now coming to the cancer anal canal. So nothing big discussion in cancer anal canal. It is all depending upon the type of cancer. Cancer anal canal, if it is a squamous cell cancer, that is straightforward, no surgery, only we do what? No need of surgery for squamous cell cancer, we do chemo radiation. So it is 5-fluorouracil based chemotherapy followed by radiotherapy. 5-fluorouracil based chemotherapy followed by radiotherapy known as Negro regimen. That is known as Negro regimen. And for adenocarcinoma of the anal canal, so it should be treated like a CA rectum and we have to go for APR. Adenocancer of anal canal should be treated like a CA rectum and APR will be advised. And malignant melanoma of anal canal, the third common site is anus. That patients we should go for wide local excision. Is better option than APR. So no need of APR for melanoma. Wide local excision is enough. If there is a malignant melanoma, we have to do wide local excision instead of going for APR. So these are the 3 cancers in the anal canal. The management is very straightforward and simple. So please remember, if it is squamous cell cancer, Negro regimen, this is 5-fluorouracil cisplatin based chemotherapy, and adenocancer APR, and malignant melanoma wide local excision and APR. Please don't forget these points. Let me show you the slides now. So just see the slides. Now we are going to see the images from this chapter. So we have discussed cancer of rectum and anus. So it is one of the important chapters for final years. Please remember the various surgeries I explained to you. So now I will show you some of my patients. This is the investigation of choice for staging cancer rectum. Please don't forget. This is what investigation is this? This is surface coil MRI. Surface coil MRI. You can see the surface coil MRI shown here. So you can see this is rectum and this is mesorectum. And any cancer infiltrating the mesorectum nodes, everything T-staging and N-staging best obtained with this surface coil MRI. Okay. And you can see this is the commonly done operation for cancer involving the puborectalis muscle. The cancer is very close to the puborectalis muscle. So we have done an abdominoperineal resection of Miles operation. And in this operation, please don't forget how many centimeter clearance you give in this operation. The clearance given in this operation is 2 centimeters, and it is done 2 centimeter margin we have to give, and after giving that margin we cannot get a sphincter continent. So what we do is we remove the distal part and we make a proximal colostomy known as APR. So how many centimeters from anal verge do we do this procedure? Up to 6 centimeter. Less than 6 centimeter from anal verge, APR is done. More than 6 centimeters from anal verge, we do anterior resection operation. So this is a picture showing you a anterior resection operation. Above 6 centimeters from anal verge, we do this anterior resection. You can see a colorectal anastomosis done with the help of circular stapler. We have discussed in the first chapter itself about the circular stapler. We will do a circular stapler anastomosis for these patients. And you can see this is one of my patients. And what you're seeing in this image, is a case of APR. You can see there is a cancer in this place. And for the cancer, I have come up to the anal skin. I have removed distally up to the anus. And I also removed this. What is this? Yellow structure, yellow bilobed structure, looking like an infant's buttock. Infant's buttock appearance or bilobed shiny structure is known as mesorectum. So this picture is showing you total mesorectal excision for a lower rectal cancer. TME, total mesorectal excision. So this is one of my recent patients. You can see a cancer just very 4 centimeters from the anal verge. So I have did a APR, and this is a complete mesorectum excised, and the patient is living with a permanent lifelong colostomy. He is living now. He is living with a permanent lifelong colostomy. Please don't forget this point. So that completes the cancer rectum. I hope you understood what is Brunswick operation. It is a pelvic eventration operation done for cancer rectum. Brunswick. What is papillon technique? Papillon technique is intra-cavity radiotherapy. What is high anterior resection? Anterior resection done above peritoneal reflection is high. Below peritoneal reflection is low. APR is landing with permanent colostomy. APR lands up with permanent colostomy. Please don't forget that point also. Lands up in permanent colostomy. And what is Negro regimen for? Negro regimen is for chemoradiotherapy of squamous cell cancer of anal canal. Okay. So that completes the rectum and anus for our discussion. Thank you.